يلا عبد الرحمن. بسم الله الرحمن الرحيم. Welcome everyone in this new meeting of Egyptian Society of Nephrology and Transplantation CME chapter meetings. I am really pleasured and honored today to have my dear professor, Professor Dawlat Bilal, as a moderator of this session. Professor Dawlat is an emeritus professor of nephrology and medicine in Cairo University. She is the head of scientific committee of Egyptian Fellowship of Ministry of Health and the past president of RAASi Center for Nephrology, Dialysis and Transplantation. Our great speaker today is Professor Mona Roshdi. Professor Mona is Professor of Medicine and Nephrology, Cairo University, and is currently the head of Internal Medicine, a department in New Giza University. Professor Mona is the board member of Egyptian Society of Nephrology and Transplantation, and she is responsible for the website of the society, which is now currently growing and is looking very different than before. And I invite you all to visit this website, which we will find it very beneficial and useful and attractive, as Professor Mona designed it in a very attractive way. And we all thank her for this effort. We will speak today about a very important topic in nephrology and even in cardiology, diabetology, but we'll touch it from nephrology side, which is optimizing RAS inhibitors in patients with chronic kidney disease and dialysis. When to use, how to use, when to stop, how to stop, and how to manage complications, etc. So we expect a very interesting lecture and a very scientific discussion later on. Please, Professor Dawlat, start the meeting and start this meeting and further introduce Professor Mona.
Thank you very much, Yasser, for allowing me to moderate this interesting topic, very interesting and useful and practical topic. I'm very happy to present Mona Roshdi, who is my student, as well as a very eminent professor of internal medicine and nephrology, with a very kind nature and easy to go person, and easy to explain whatever she has to explain. Today's topic is optimizing the RAS inhibitors in chronic kidney disease and dialysis. She very recently spoke about RAS inhibitors in transplantation in the last transplantation chapter of the ESNT meeting last week. So I think she's interested in the business about RAS and RAS inhibitors wherever they are used. So please start, Professor Mona.
Thank you very much, Professor Dr. Dawlat, for your kind introduction. Actually, Professor Dawlat is my professor and my role model, and I thank her very much about this kind introduction. I apologize also for being a little bit late, and I will start immediately the presentation about optimizing RAS inhibitors in CKD and dialysis. I will talk about the following points: benefits and approved indications of RAS inhibitors, hypertension guidelines in CKD regarding RAS inhibitors, RAS inhibitors in advanced CKD. I will highlight the important studies and trials done in this respect, RAS inhibitors in diabetic nephropathy, RAS inhibitors in hemodialysis patients, in renal transplant recipients, and how to manage the complications associated with their use. And very briefly, I will touch the combination with other drugs and the benefits of these combinations. I will not go, I tried during preparation of this presentation to make it as practical as possible, so I will only remind you with the broad lines of the RAS blockers having a hemodynamic effect and humoral and other factors effect. effect. So they manage hypertension, or they treat hypertension. They treat sodium and water retention and hyperfiltration, and they decrease aldosterone excretion, decrease inflammation and oxidative stress, which is associated with the pathological condition associated with renin-angiotensin renin-angiotensin acceleration, يعني in a pathological condition. These effects are mainly on two organs. There are cardiac effects and renal effects. Regarding the cardiac effects, there are left ventricular hypertrophy, which is attenuated by the RAS blockers, the cardiac fibrosis and arrhythmias. And regarding the renal effects, they try to decrease the progression of kidney disease, they decrease proteinuria, and they decrease renal fibrosis. We have to know that chronic kidney disease and cardiovascular disease are going hand in hand, and in inverse, strong and independent relationships exist between the estimated GFR and the risk of cardiovascular morbidity and mortality. The burden of cardiovascular disease, particularly due to heart failure or the development of cardiac arrhythmias, is multiplied in those with end-stage renal disease in chronic dialysis. And this information is very important because it will manipulate, or it will influence our decisions regarding starting or stopping ACE inhibitors. Regarding the indications, these are the FDA-approved indications of ACE inhibitors. They can be used to treat hypertension, either alone or in conjugation with other antihypertensive. They are given or treated, prescribed to patients with chronic kidney disease, patients with coronary artery disease and hypertension. They are recommended as part of a regimen in patients with hypertension and chronic stable angina if there is history of left ventricular dysfunction, diabetes, or CKD. In patients with heart failure, they are useful as adjunctive therapy in systolic heart failure. They also help to prevent and treat heart failure in patients with reduced ejection fraction who also have a history of myocardial infarction. In myocardial infarction, they are given to patients with ST elevated myocardial infarction. They should be initiated within 24 hours, specifically in patients with anterior MI, heart failure, or left ventricular ejection fraction. So as you see, there are many cardiovascular indications in which ACE inhibitors are very important. Then I will revise very briefly the blood pressure management in patients with CKD with or without diabetes not receiving dialysis, in order to identify the patients who are mostly to benefit from these drugs. First, I will remind you about the target. It is less than 120 millimeter mercury. Then they are recommended to patients with CKD and severely increased albuminuria. So they are benefit more patients with albuminuria. They are also prescribed to patients with moderately increased albuminuria, grade 1 to 4, A2 without diabetes. As regards the patients with diabetes, they are prescribed or beneficial for patients with moderate to severe increased albuminuria. As you can see, the last point is that we should avoid any combination of ACE and ARBs, although I will show you some recent, relatively new studies which try again to combine the ACE and ARBs, and I will come to this point later. In patients with CKD with diabetes, the recommendation presents, which I mentioned now, apply only to patients with CKD from grade 1 to grade 4, since there is currently no evidence on the use of these agents in grade 5. So I will highlight in the following section the trials and studies which are performed on patients with CKD. But till the last guidelines, blood pressure guidelines, which were published in 2021, these recommendations are applied only for patients from grade 1 to grade 4. Then we have some practice points which are present in the guidelines, that we should use the highest approved dose that is tolerated to achieve the benefits, as these benefits were achieved in trials using these doses. Changes in blood pressure, serum creatinine, and serum potassium should be checked within 2 to 4 weeks, depending on the current GFR and serum potassium. Hyperkalemia associated associated with the use of RAS inhibitor can often be managed by measures to reduce the serum potassium levels rather than decreasing the dose or stopping RAS inhibitors, and I will come later again to this point. Here, I want to show you the doses of ACE inhibitors regarding the initial doses and maximum doses, as we have to titrate up the dose in patients to achieve the best response of the drug, guided by the serum creatinine and potassium. And these are the doses regarding for heart failure and for hypertension. During follow-up, if the creatinine rises by more than 30% within 4 weeks, then we have to stop the drug, and we have and also we have to discontinue the drug in the setting of either symptomatic hypotension or uncontrolled hyperkalemia despite medical treatment, or to reduce uremic symptoms while treating kidney failure. In patients without with the CKD, with or without diabetes not receiving dialysis, might increase albuminuria. Consider starting in people with CKD with normal or mildly increased albuminuria for specific indications. So if the patient is CKD patient, but the albuminuria is mild, we can give him the ACE inhibitors, but this for the other indication, as for example hypertension or heart failure with low ejection fraction. As regards the transplant recipients, the guideline states that we can use, recommends that we can use dihydropyridine calcium channel blocker or an ARB as the first antihypertensive treatment to be used in adult. They are both at the same level of recommendation. Here, these are the guidelines showing the target recommendation, and these are our guidelines recommending the KDIGO guidelines recommending a target of less than 120 systolic blood pressure. Then in the following section of the presentation, I will highlight the new or the trials and the studies which were done on patients with advanced chronic kidney disease, stage 4 or 5, or the GFR less than 30. The problem is usually that we have concerns from previous observational studies that the use of ARBs, use of ACE or ARBs, either as initiation or as a continuation of a drug already used, that is associated with rapid acceleration of the chronic kidney disease and the development of renal replacement therapy, and the end-stage renal disease, development of end-stage renal disease. So we have to look to these data from this study, which was published in Journal of American Society of Nephrology, where 10,254 prevalent RAS inhibitor users were assigned to a study. 15% stopped the RAS or RAS inhibitor they used within 6 months, and the duration was 5-year follow-up. The outcomes were subsequent 5-year all-cause mortality, major advanced cardiovascular effect, and initiation of kidney replacement therapy. And what they found that discontinuing this treatment is associated with increases in the 5-year absolute risk of mortality and major adverse cardiovascular effect, but there is an increase, 8.3 decrease in absolute risk of initiating kidney replacement therapy. So when stopping the RAS inhibitor, there is more incidence of adverse cardiovascular events. However, there is a better outcome regarding the kidney. This was the result of this observational study. This is a meta-analysis showing many studies which were concentrated on the cardiovascular outcomes and the renal outcomes, and most of the cardiovascular outcomes during continuation of the drug was in favor of the cardiovascular outcomes, while the renal outcome, there are conflicting or confusing results. Some studies show that it favors initiating RAS inhibitor or favors initiate or continuing RAS inhibitors, and sometimes it is not in favor in good outcomes regarding the renal outcomes. This is another study where discontinuation of ACE inhibitor therapy with total and cardiovascular death and coronary artery disease patients with advanced chronic kidney disease. These patients were chronic artery disease patients with advanced CKD, and the outcomes was all-cause mortality and cardiovascular death also for 3 years. This study included patients on dialysis and patients not on dialysis, and it shows here that regarding the patients with, here we find that patients with not on dialysis, they have a statistically significant difference between patients who discontinued the treatment and patients who are continuing the RAS inhibitors, while in patients with dialysis, there is no difference in the outcomes between two groups. So here are the results. Stopping was associated with higher risk of cardiovascular events after hemodialysis initiation and not associated with mortality. The subgroup of analysis for cardiovascular events revealed that the association was consistent except for the subgroup of age more than 75 years. The cardiovascular risk of stopping RAS inhibitor was especially higher in the subgroup with age less than 75 with a significant interaction. So here the effect is more in the patients with advanced chronic kidney disease rather than patients on hemodialysis. This is an relatively old study from 2006, where someone can think if there is any difference between is there a specific anti-ACE inhibitor which is preferred in patients to or give better outcomes than other members of ACE inhibitors. And here this is a study from 2006. Renal insufficiency, and it was compared to a placebo. So this study is very important, and it is considered one of the landmark study because it is a multi-center open-label trial, and it included patients with advanced and progressive chronic kidney disease with GFR less than 30, either to discontinue or to continue therapy with RAS inhibitor. It was called the Stop ACE inhibitor study, and it was published in 2022 in New England Journal of Medicine, and it is considered a very important study or a landmark study in this respect of continuing or discontinuing RAS inhibitor. The outcomes was two outcomes. The first outcome was eGFR at 3 years. They concentrated on the eGFR, if the GFR is going to deteriorate or to decrease or not between two groups. And secondary outcome includes a composite decrease more than 50% in GFR or initiation of renal replacement therapy, if there is any difference in hospitalization, if there is a difference in hypertension, exercise capacity, or quality of life. But I want to show you the next slide and return back to this slide. So I will show you the results. Then I will show you then the population of the study, how they went. Results show that there is no statistically significant difference between the GFR of both groups. And these are the rest of outcomes, the secondary outcomes. Both were nearly equal in both groups, and also there was no change in hospitalization or quality of life of blood pressure, slightly increased at the start in the discontinuation group, but then both are normal, or also the complications were both within normal. But I would like you to look at this slide. This slide shows that the start of the study was with 17,290 patients. And then some patients were excluded. Here we see here that then 799 were excluded. And then they started the study actually after screening of 17,290 patients to 411 patients. And these were randomized in 206 and 205. And again, at the end, we ended up to 165 patients on both groups, starting from 17,000. Can you imagine that starting 17,000 patients are screened and then only these patients are included? Why? I read it very carefully. I found that they selected patients with a decline in GFR of 2 milliliter per minute per year. So they have a very strict selection criteria in order to select a more or less stable, I think, patients. And so the outcomes were favorable regarding the GFR. This study didn't show any outcomes regarding cardiovascular mortality and didn't concentrate on this point of importance in patients with cardiovascular disease. But it is considered one of the landmark studies that we can, from which we some physician or nephrologist can conclude that they can continue RAS inhibitors for the sake of the cardiovascular outcomes, while they are not harming the kidney, or they will not have bad or unfavorable outcomes of the kidney, depending on this study. Although this study, the patients were selected very strictly. So the conclusion of this study was, among patients with advanced and progressive chronic disease, the discontinuation of RAS inhibitors was not associated with significant between group difference in the long-term rate of decrease of the GFR. This is a study concentrating on coronary artery disease patients with advanced chronic kidney disease. So advanced CKD was defined as estimated GFR less than 30, and the patients with ACE and ARBs who continued the treatment shows a better survival benefit. I am showing you this study only to emphasize that all studies show or have or include heterogeneous population. And also when we are dealing with our patients, we have to look very well to our patients, and we should individualize the treatment, because as we can see here, the patients we have in coronary artery disease patients, so it was better to leave them, or the group who continued ACE or ARBs showed a better survival benefit. This study was published in American Journal of Kidney Disease in 2023. This compares RAS inhibitors with calcium channel blockers, and this study shows results showed that the population was very heterogeneous, and so they had to do it during the statistical propensity score, and so there is significantly lower risk for kidney replacement therapy after the new use of RAS inhibitors compared with the new use of calcium channel blockers. So this study also and these results show that there is a lower risk after use of RAS inhibitors. Both drugs show similar risks for mortality and MACE or major atherosclerotic cardiovascular events. So these studies were all examining the advanced CKD, but some of them included included also diabetic patients. But there are some studies which were dedicated to diabetic patients, as this study, which was prospective population-based cohort, including 10,400 patients with type 2 diabetic patients. And it shows here, as you can see in the results, a statistically significant difference between the groups as regards the heart failure and the cardiovascular events. And but there is no effect, no difference in the all-cause mortality. This is a systemic review and a meta-analysis containing 9 randomized controlled trials. The outcomes was all-cause mortality, cardiovascular mortality, non-fatal cardiovascular events, and then renal outcomes, evaluating the number of events of renal replacement therapy and changes from baseline of GFR. And here in the diabetic group, there was no difference between both groups, and there is a trend for a favorable effect of RAS blocking agents for non-fatal cardiovascular events, and the lower risk for the composite outcome or need for renal replacement therapy. Also, regarding the benefits of ACE versus ARBs on renal and cardiovascular mortality, there are insufficient data, as only 3 trials used a head-to-head comparison between these 2 types of agents, suggesting insignificant difference between ACE and ARBs in patients with diabetic nephropathy. There is this also this study was concluded by that ACE inhibitors reduced all-cause mortality, cardiovascular mortality, and major cardiovascular events in patients with diabetes, whereas ARB has no benefits on these outcomes. This study was comparing ACE and ARBs, and ACE should be considered as the first line to therapy to limit excess mortality. This study is from 2014. Also, I looked for some study to show to look for any difference between ACE and ARBs. Regarding hemodialysis patients, this study was a retrospective cohort study, evaluated the data of 717 incident dialysis patients, and the duration of the study was 3.5 years in mortality and in cardiovascular events. Here we see that the discontinuation of RAS is associated with higher cardiovascular events. And this is another study in dialysis patients. This is a systematic review and meta-analysis involving 1,582 patients, and it compares the ACE and ARBs relative to placebo or no add-on treatment in patients receiving dialysis. It shows that the use of ACE or ARBs was not associated with significantly lower risk of cardiovascular events, cardiovascular or all-cause death. This study also shows that patients receiving ACE and ARBs had comparable survival, and patients receiving ARB had a better survival in the subgroups of patients with diabetes or heart disease, and patients receiving ACE had better survival in the subgroup of young patients without diabetes or heart disease. So as you can see, in patients with hemodialysis, the evidence is not very the evidence is not very confirmed that in patients with hemodialysis, the continuation will add a cardiovascular benefit. So it is not consistent along the different studies I showed to you. I would like to show you this slide regarding the hemodialysis to remind you that we have to think during treatment of patients with hemodialysis that most of the ARBs are non-dialysable. Here they are not removed during hemodialysis, and there is also prolonged duration here of the ACE inhibitors if they are given to the patient, and also they are dialysable. Most of them are dialysable. So regarding the hemodialysis group, there is a patient heterogeneity and lack of comparative evidence. So they cannot give us a firm recommendation of one class of drug over the other for all dialysis patients. More ARBs are not dialyzed, as I showed to you, during conventional dialysis and can be used for sustained blood pressure reduction. However, randomized controlled trials have failed to confirm the benefit of RAS inhibitors in dialysis patients as in the general population. In some studies regarding the hemodialysis, beta blockers may be used as a first line, and they control the sympathetic overactivity of left ventricular hypertrophy and may contribute to high incidence of arrhythmia and sudden cardiac death. Regarding the renal transplant recipients, in meta-analysis, one meta-analysis shows that blood pressure lowering medication to protect transplanted kidney and prevent heart complications. So the key messages from this meta-analysis show that calcium channel blocker to lower the blood may prevent death and the loss of transplanted kidney, but make little or no difference in the kidney function compared with placebo or standard care, where angiotensin converting enzyme inhibitor may be used, but no preference one of them. Then I will move to the complications. This study shows that after I explained the benefits of the ACE and ARBs and how they are beneficial as regarding the kidney, as regarding the heart, then this study was examining how many of the doctors are prescribing them. We show here, according to this study, that the use of ACE and ARBs is 28% among all participants, while during analysis by age group, the less than 75 years per patients, less than 23% of patients are using ARB according to the age less than 75, and in ages more than 75 the use is 41% according to this study. This is a very interesting study which was published in 2023, and it shows they performed a questionnaire to nephrologists, and they asked him, would you stop RAS blocker in certain GFR? And so here we find here no, that we can 46 of doctors responded that they would continue RAS blocker, and many of them raised the concerns of hyperkalemia and were worried about hyperkalemia in patients with advanced kidney disease, that they may occur at higher incidence. So what is the incidence of hyperkalemia in patients which are prescribed RAS inhibitors? We find here that among patients with uncomplicated hypertension, it is low as 2%. And there are specific risk factors for hyperkalemia, which is GFR less than 45, older age, diabetes, heart failure, and so if they are taking RAS blocker. And this meta-analysis shows many randomized control studies where here the incidence, we can see the incidence of the RAS inhibitors. The incidence of hyperkalemia in RAS inhibitors here is 1.4%, 24%, and so the level is higher according to the study, and it is higher than this level also if we have combined ACE and ARBs. And this studies, this was published in 2018, and then with the occurrence of the new with the new potassium binding resins in hyperkalemic patients, there are some nephrologists studying once more the effect of combining ACE and ARBs, and some studies are ongoing back again combining ACE and ARBs. And here is the effect of in different studies when using the potassium binding resins in hyperkalemic patients. Here the potassium level is all reduced, and they can continue the treatment and benefiting from ACE inhibitors. The newer agents are patiromer and sodium zirconium cyclosilicate, but I will not go into the details. So how to deal with complications accompanied with ACE and ARBs? We have to monitor the serum creatinine and potassium, as I mentioned, within 2 to 4 weeks. If the patient has hyperkalemia, if he is normokalemic, the patient, and doesn't have a decrease in more than 30% in the GFR, we have to increase the dose and up-titrate the dose till we reach the maximally tolerated dose. And if the patient develops hyperkalemia, we have to review concurrent drugs, moderate dietary potassium, and consider the use of diuretic potassium and sodium bicarb and potassium binder. If there is increase more than 30%, we have to review the causes if there is another cause of AKI, or if the patient is taking concomitant medications as diuretic or non-steroidal, if the patient has volume depletion due to any cause, and maybe we can think also about the diagnosis of renal artery stenosis. So in this case, we have to reduce the dose or even stop the ACE or ARB. This slide show how to manage hyperkalemia. We have to assess the function. We have to do dietary modification, and if there is any acidosis, it should be treated. We have to use the potassium binder, as I mentioned, and the new generations of potassium binders. We have to check the patient medication profile. and we can give the patient some diuretics, small amount of diuretics to counteract to decrease the hyperkalemia. The use of sodium glucose transporter, I will talk about it immediately after this slide, and the early introduction of finrenone, the non-steroidal, which is associated with less incidence of hyperkalemia, and all the precautions I will mention it very briefly. So the combination, the last section of the presentation is about the combination of the drug. According to the guideline, we combine the first drug therapy for most patients is sodium glucose transporter, which is continued until dialysis or transplantation, and the ARBs together with the ACE or ARBs, RAS inhibitor, and then as the second step, we can use a non-steroidal mineralocorticoid antagonist. According to the guidelines, sodium glucose transporter is recommended in patients with type 2 diabetes, CKD, and more than 20 milliliter per minute GFR. And if the GFR is more than 20 milliliter per minute with urine ACR more than 200, or heart failure, irrespective of albuminuria, or in patients with 20 to 45 milliliter per minute with urine ACR less than 200 within sodium glucose transporter. These are the studies which started all to attract our attention about the use of sodium glucose transporter, which are DEPA, CKD, and IMPA chronic kidney disease. And this is the multiple trials which show here that sodium glucose transporter are better, and the combination therapy with sodium glucose transporter and renin-angiotensin blockers actually show a much higher level of protection and lowering of the major atherosclerotic cardiovascular events, cardiovascular death, or heart failure, and they have increased protection to the patient. Mineralocorticosteroids, receptor antagonists with proven kidney or cardiovascular benefit within GFR more than 25, normal serum potassium concentration at albuminuria despite maximum tolerated dose of RAS inhibitor. Both these drugs are new drugs and very promising drugs, although in the last 30 years, the RAS inhibitor was the only drug prescribed and the only important drug. But however, these drugs should be only given to the patient after RAS inhibitor or in combination to RAS inhibitor. These are the studies which started the non-steroidal mineralocorticoids use, and then it became approved. However, we have to pay attention to potassium again very strictly upon addition of the non-steroidal mineralocorticoid receptor antagonist. Here, this is the last study, is ongoing study, which is studying the combination of finrenone and empagliflozin. Conclusion: discontinuation of angiotensin converting enzyme inhibitors or angiotensin receptor blocker in patients with advanced CKD does not significantly improve kidney function, but it may be associated with increased cardiovascular events. Despite concerns, RAS inhibitors continue to offer significant benefit more evident in advanced CKD, including blood pressure control, cardiovascular protection, and reduced mortality risk. Optimizing means maximizing the benefits and minimizing the risk. We have to individualize therapy among patients with advanced CKD based on heterogeneity of the treatment response by factors such as age, race, cause of CKD, comorbid conditions. Careful patient selection and dose adjustment is essential to optimize therapy and minimize adverse effects. We have to monitor the patient closely for hyperkalemia, hypotension, and acute kidney injury. Regarding the hemodialysis group, patient heterogeneity and lack of comparative evidence didn't confirm any recommendation of one class over the other in all dialysis patients, and the benefit of RAS inhibitors in dialysis patients was not confirmed, waiting for further studies. Thank you.
Thank you, Professor Mona, for this very interesting and comprehensive lecture. Please, Professor Dawlat.
Yes, thank you very much, Mona. You made a great effort to collect all this knowledge. يعني I personally have a few questions. Number
Yes.
one, I think you mentioned and confirmed that the treatment has to be individualized,
Yes.
right? Do you have any preference for ACE inhibitor over the ARBs? Because now the trend is everybody is using ARBs. يعني, so is there a preference? At one point you said that ACE is better in some in circumstances than ARBs. One of the points you mentioned this.
Yes, in one study, one of the studies I found it was from 2006, and it was an old study. It showed that ACE inhibitor showed a better kidney outcomes, but it is one study, and the studies are observational,
All right.
so
So
it's not of high evidence. Yeah.
okay, so the main indication in chronic renal failure to use the ACE or ARBs is to treat the hypertension, right?
Yes, and to
But you mentioned that
prevent
it
progression
is not
and to
the first choice. Is it the first choice or you start by calcium channel blocker?
no first in ACE in chronic kidney disease.
Yes,
Yes, in proteinuric chronic
It-
kidney disease,
yes. From
they
stage
are
1
of
to
choice.
4,
Yes, in chronic kidney disease, they are of choice in stage 1 to 4 according to the guidelines.
yes,
In proteinuric CKD, they are especially beneficial.
right. Okay, and in dialysis patient, what is the indication in dialysis patient? Hypertension?
Yes, hypertension in the or
Hypertension, yes.
other cardiovascular indications, heart
And,
failure, reduced
yes,
ejection
yes,
fraction, or ischemic heart disease.
yes.
But the
And
studies
at
didn't
some
show
stage,
their
at some
importance.
time, it was allowed to combine both. Now it is not advised to combine both ARBs and ACE, or at least they said,
Yes.
يعني, we can combine. لكن يعني ما كانش recommended قوي.
Yes, in the guidelines, we are up till the guidelines of 2021, we are not, we cannot combine. It is not,
Yes,
we cannot combine. It is not, we are, we're not allowed to combine. Okay, this according to the
right.
guidelines. But
Oh,
with the new anti-hyperkalemic measures, there are some emerging studies which again talk about that we can try again to
to
find,
combine.
yes, to combine in order to have the benefit of the combination. The studies of the combination, they were stopped because of side effects, and mainly the side effects were hyperkalemia.
Hyperkalemia, yes.
But up till now, according to the guidelines, we are not to combine.
Or not. Yes, all right. Thank you very much. This is a very good effort and very informative. Thank you very much. Now we open discussion for the audience.
Professor Said Khamis wants to comment. Welcome.
السلام عليكم دكتور ياسر، دكتوره منى، دكتوره دولة.
عليكم السلام ورحمة الله وبركاته. أهلا بحضرتك.
ازي حضراتكم يا فندم؟
الحمد لله.
معلش انا دخلت متاخر شويه وبس الى حد كبير يعني وصلت للكونكلوجن بتاع حضرتك ان الجزئيه يعني زي ما بيقولوا الباب متوارب، بس يميل اكتر ان نستمر عشان الكارديو ورينو بروتكتيف افكت بتاع الايس او الاربس، وخصوصا ان هي الى حد كبير من معظم الدراسات اللي حضرتك استعرضتيها ما اثرتش بقدر المزعج على الجي اف ار. يعني مش ده الكونكلوجن صح؟
هو الحقيقة الترايلز which I showed were heterogeneous. يعني actually they were heterogeneous.
هي ميكسد ريزلت.
The population they recruited, or the patient they recruited, were يعني some trials recruited patients with ischemic heart disease or coronary artery disease, and the study يعني they stress on this study قوي، وقايلين ان هي this is a landmark study which was published in New England Journal of Medicine.
اللي هي ستوب ايس.
Yes, because it is not observational. It is
randomized controlled.
Yes. And so they found that the evidence. Even this study, I showed them that they started with 17,000 patients. يعني it is a multicentric study, and they started with 17,000, and then the study ended up with 200 patients out of 17,000. This means that the study there was very strict selection of these patients to end up in this good result.
يس هو السؤال بقى حضرتك يا دكتوره منى بالنسبه للامبراكتس،
Yes.
واعتقد يعني حضرتك هتوافقيني واستاذتنا الدكتوره دولت واخونا الفاضل الدكتور ياسر والزملاء كلهم، في تو ايفنت او تو سيتويشن بنقع فيها احنا كنيفرولوجيست. نمره واحد عيان اي كي اي، ونمره اثنين عيان السيكي دي اللي هو بوردر لاين ما بين 4 و5، ستيج 4 وستيج 5. ببقى حاطط يعني سوري انا هتكلم بالبلدي شويه، ببقى حاطط ايدي على قلبي من الايس او الاربس في الحالات دي، وما لو هو ماشي عليها بهولد، مش هقول بستوب، اتليست بهولد لحد ما اشوف الدنيا ماشيه ازاي. لو هو مش ماشي عليهم خلاص ما بعملش انترودكشن للايس او الاربس في المراحل دي. اعتقد ده كومن في البراكتس بيحصل، والفوبيا ما زالت عند معظمنا ان احنا يعني والله ده العيان اي كي اي يا ريت بلاش ايس او اربس، ده العيان ستيج 4 سيكي دي، سبيشال لو كان الدر بلاش. اما يدخل في ستيج 5 ويدخل على داياليسيس بقى بسبب او لاخر بالبروجريشن العادي ليتر اون، وارد ابتدي تاني الايس او الاربس. فهل حضرتك موافقاني على ان ده اللي بيحصل في البراكتس فعلا، ولا انا مبالغ شويه؟
Okay, I can agree about certain points. يعني in the elderly patient, I should be very careful. Yes, you are right. Because he, at any time, the patient takes a non-steroidal anti-inflammatory, or he is taking Lasix for any cause, or enters in a bout of acute diarrhea, or anything that يعني would compromise his kidney function. In the elderly patient, you are absolutely right. Second, initiation. There is a difference between initiation and continuation. You are absolutely right. I will not dare to start. Yes, you are right. To start an ACE inhibitor in advanced chronic kidney disease is very risky. Yes, I agree about that. And then we are left with continuing. To continue. When to continue? I can tell you about a patient. I had a patient with she was a psychiatric patient and taking lithium, and this lithium caused for her a chronic kidney disease, and she was hypertensive. She is about 40 years old, and I started for her ACE inhibitor.
Yes.
And then she developed a gradual rise of creatinine. It was not 30% as the guideline said. It was less than 30, but it was persistent. It was persistent all over 6 months. She comes, and then the creatinine kept rising.
Yes.
This patient was not proteinuric. The proteinuria was minimal at this patient. She has a chronic kidney disease with minimal proteinuria. And then I was surprised from this rise of serum creatinine, and she stopped her treatment. I don't find an explanation as the point that I did for her a renal biopsy. Of course, I was not sure why is this creatinine rising. Then I decided to stop the ACE because she is not proteinuric. So according to the guideline, she is not very indicated, and then she is deteriorating with this ACE inhibitor. And I switched her to calcium channel blocker, and surprisingly, she was doing well. She was not in stage 5. She was in earlier stages. I think she had GFR or 40 or something like this. I don't remember.
Yes.
But I mean, here I stopped it because I don't find it beneficial, and there is progressive rise, which is I cannot explain. Maybe there is some reduction of GFR at this patient.
وارد طبعا.
Was this patient يا منى this patient can continue on lithium ولا stop
No,
the
she
lithium?
stopped it. She insisted that she stopped it.
تمام. طب في
I think you have to
نقطتين سريعين يا دكتوره دولت تسمح لي.
you have to think about lithium here.
ممكن بس
this could
ممكن
be
ده
the
وده يعني هم نقطتين سريعين.
This could be the effect of lithium as well.
It can be.
يعني lithium has a cumulative effect that takes a long time to develop, and she might have been in this stage developing lithium problems.
Yes.
I looked it up. I did a research on this respect of lithium. I found that it can be even if she stops it, kidney progression may occur.
دكتورة منى في سؤال عن البيوبسي ريزلت. ايه البيوبسي ريزلت طلعت ايه؟
biopsy results.
I think interstitial fibrosis.
يعني الليثيوم ممكن يكون وارد طبعا.
وارد
lithium.
طبعا. وارد.
in
lithium will cause
psychiatric patients they have to do a drug level. They have to do a drug level يعني regularly.
Yes, yes.
اسمحي لي
yes.
دكتور، اسمحي
I think
دكتور
in
دولة
another
حضرتك.
occasion, if the patient has ischemic heart disease and heart failure and was a cardiac patient, and in another case, I would leave the ACE inhibitor, the ACE or ARB.
Yes.
And let
So
me
it
take
depends. It depends on the patient,
Yes,
on
yes.
all his condition.
let me take this point دكتورة منى، وبرضه أكمل إجابة مع السؤال دكتور سعيد. Not usually to stop ACE في حياة الأكيوت كدني إنجري دكتور سعيد، يعني in my practice even with these cases especially with cardiorenal syndromes and heart failure, I do not stop ACE. I do not stop ACE, and the many patients went well with usual management without stopping.
هي
ACE.
الفوبيا، بس الفوبيا ساعات
في
بتاخدنا
فوبيا
شويه
طبعا،
دكتور.
في
لا
فوبيا
بس
والريزلتس.
again دكتور ياسر, you are
Yes.
talking about cardiorenal, okay?
Yes.
Because the ACE is beneficial for the heart, which is causing the renal.
دي حقيقة.
We can stop in case of hypertension or something like that.
Can I mention something for Professor Saeed? You mentioned two scenarios. The first one is acute kidney injury.
Yes.
I don't think you can give an ACE in acute kidney injury to start with. يعني. Number one. The scenario is a stage 4 to 5 patient where you want to initiate ACE. This is, of course, should be very careful and critical, and you will measure the potassium and serum creatinine rise probably.
Sure.
Yes. It's very risky.
Yes.
If you have I would use another alternative. I will not use except if he needs it for the cardiac condition. Then I will consider it, and you have to be very skeptical and careful.
For sure.
Right? The other thing, the patient with lithium. Lithium is very notorious to cause interstitial problems and tubular injury.
Yes.
It causes renal tubular acidosis, one of the problems.
Yes, I thought about it, but she didn't have. She didn't have renal tubular acidosis. I
She did not. Anyway, يعني 2 hits to the kidney will be very serious to give her an ACE, and on a background of lithium for a long time. Of course, you have to be very careful. Yes. If you really need the ACE.
المشكله في اكتشاف الار تي اي، وجود الرايس اوف سيرم كرياتين هيبقى ديفيكالت او امبوسيبل، لان طبعا اليوريميك ايفنت دخلت عملت لنا هاي اناين جاب، فهتلخبطني، مش هعرف احدد اذا كان نورمال اناين جاب ولا لا. لكن anyway الجزئيه الثانيه الناس اللي بنبتدي لهم ايس او اربس وبيرفعوا الكرياتينين لاقل من 30% وكلام من ده، احنا واخدين الامر برضو شويه انه يعني انوسنت. هو مش انوسنت قوي، يعني في بعض الدراسات لقت حوالي 10% من الناس اللي حتى الكرياتينين اللي بيرفع اقل من 30% من البيز لاين بيزيد فيهم الكارديوفاسكولار موربيديتي ومورتاليتي، يعني ايفن سو يعني. فمش معنى كده ان انا بقول ما نديش او نوقف او كلام من ده، بس برضو نحتاط من هذا الامر. الجزئيه الاخيره بقى اللي هو الناس اللي على دياليسيس، والسؤال البيزك اللي دايما بنقعد نساله وان كانت اجابته الى حد كبير معروفه، اللي هو طب انا هدي ايس او اربس او هخليه يكمل على ايس او اربس، انا خايف من الهايبركاليميا ليه؟ لو الجي اف ار بتاع العيان ده 1 مللي لتر بالمينت او ما فيش، او هو انفرك العيان، حتى هو هيجيب منين تيوبيولز عشان يعلي الالدوسترون تشتغل عليه ويعلي لي الايه البوتاسيوم؟ ما فيش، المفروض العيان اند ستيج.
It was not raised قوي يعني في ال patients with hemodialysis this was not evident قوي الهايبركاليميا.
ما انا واخد بالي يعني، بس خصوصا لو خد اذر ميديكيشنز دخلت في القصه يعني.
هو بس
لكن
ARBs are preferable because they are not dialysable.
اي نو، بس هو الفكره قيل ان الجي اي له او الجاستروانتستينال تراكت له دور في القصه دي، او ان الالدوسترون بيشتغل على الجي اي، وبالتالي بيعلي لي موضوع الابزوربشن بتاع البوتاسيوم ويديني سام سورت اوف هايبركاليميا، وان كانت مش مسببه مشكله ده بالدرجه اللي احنا بنخاف منها زي ما حضرتك قلت يا دكتور مان.
شكرا دكتور سعيد.
العفو يا فندم.
شكرا ويلكم، يعني بقى لنا فتره ما شفناش حضرتك معانا يعني.
معلش انا بعتذر والله، انا فعلا
بنسعد دايما بوجودك.
اعذرني، انا بقصر
ازاي
والله.
بنسعد بوجودك دايما.
ربنا يخليك، ده شرف ليا يا دكتور ياسر.
question
دايما
دكتورة
دكتور
منى.
سعيد very valuable، يعني discussions وحضرتك يعني بتبقى الدiscussions والكومنتس بتاعتك very valuable والcontributions.
يا فندم شهاده حضرتك دي وسام على صدرنا، شكرا يا دكتور منى، متشكرين يا فندم.
question from دكتور أحمد سعيد. دكتور أحمد سعيد our professor in قصر العيني about the use of interest اللي هو sacubitril valsartan in chronic kidney disease. Is there any specific precaution دكتورة منى or the same precautions applied for ARPs؟
لا انا الحقيقه ما عنديش اجابه السؤال ده، لا يمكن عشان ما بنستخدمهمش كتير.
I think the same precautions initiation and progression and follow up as ARPs. This is up to my knowledge.
واهم حاجه الادجستمنت للدوز طبعا زي ما حضرتك
بالظبط طبعا. المشكله في الفارزالتان افكت.
خير دكتور ياسر.
ازاي
انا دكتور سعيد اتفضل. دكتور احمد اتفضل.
دكتوره منى ودكتوره دمشت ودكتور سعيد، شكرا جزيلا.
اهلا وسهلا يا فندم.
that you let me in. انا اسف طبعا سمعت جزء من المحاضره ما سمعتهاش كلها، بس يعني الحقيقه it was very nice and interesting. فشكرا يا دكتوره منى اولا. انا كان بس عندي few comments if you allow me.
اكيد
اتفضل يا دكتور احمد.
اولا ال combination of ACE and ARBs advisable only in patients with severe proteinuria. ده الانديكيشن الوحيد اللي ما زال باقي ان احنا ندي الكومبينيشن.
يس.
ولانه الترايلز ما اثبتتش ان لهم فايده في الكومبينيشن غير انها هتافكت الكيدني فانكشن. بالنسبه للموضوع بتاع الانترستو اللي هو الساكيوبتريل فالزارتان، هو في ترايلز عليه دكتوره منى، وفي الترايلز دي في البيشنتس اللي هم عندهم هارت فيلير واند ستيج كيدني ديزيز اللي هم على داياليسيس او ستيج 5 without dialysis. والترايلز دي اثبتت الحقيقه ان هو له فيري جود سيجنيفيكانت افكت على البروجريشن اوف هارت فيلير. فهو انديكيتد لحد دلوقتي في البيشنتس اللي هم عندهم هارت فيلير وكرونيك كيدني
هارت فيلير. دكتور احمد
في الهارت فيلير.
في الهارت فيلير
انما الحقيقه دكتور ياسر it's one of the best anti-hypertensive treatments بس off label بالنسبه للبيشنتس اللي هم عندهم severe hypertension وكرونيك كيدني ديزيز. الانترست على الهايبرتنشن الحقيقه excellent.
بس not labeled for hypertension at all, labeled for
off label. It's an off label indication. بس I
yes.
think there is ongoing trial على موضوع السيفير هايبرتنشن في الكرونيك الهايبرتنشن في الكرونيك كيدني ديزيز.
بس حضرتك الدوز قد ايه يا دكتور احمد؟
الهارت فيل يا فندم.
الدوز قد ايه يا دكتور احمد؟ ازي حضرتك؟
دكتوره منال ازاي؟ صح
الحمد لله. كنت هسأل حضرتك لو هو يستخدم في الهايبرتنشن، يعني هو موصوف في الهارت فيلير، بس لو استخدم في الهارت فيلير الدوز بتاعته قد ايه؟ نفس الدوز بتاع الهارت فيلير؟ يعني بنستخدم 50 ولا 100 ولا
50 مللي جرام توايس.
50 مللي جرام توايس.
عادة طبعا بيتاخد في البيشنتس اللي هم عندهم انترا دايليتيك هايبرتنشن، يعني اللي هياخده قبل الداياليسيس ده اللي بيجي له هايبرتنشن ديورنج ذا سيشن.
هو دايلايز يا دكتور احمد؟
هو بارشلي
فالزارتان
الفالزارتان الجزء اللي فيه مش
تمام.
استاذن حضراتكم دكتوره دولت، حضرتك do you have a comment؟ اتفضلي.
لا انا I believe ان هي دي الحاجتين اللي قالهم الدكتور احمد، اللي هي الكومبينيشن اوف ACE and ARB في السيفير بروتينوريا، اللي هم ابتدوا يتراجعوا فيها تاني ان يمنعوا الكومبينيشن دي to keep an eye on the potassium. والفالسartan it's a very good drug. You are quite right on dialysis hypertension and during dialysis. I don't know if it's dialysable or not. لو dialysable يبقى ازاي يعني هاخده؟ غريبة شوية يعني.
partially dialysable يا دكتور.
دكتور احمد قال partially
لان انا لو هاخده قبل السيشن، قبل الداياليسيس
طبعا.
ممكن بعدها.
طب احنا
You are
نجربه بعد
speaking
كده
about interdialytic hypertension, right?
لا احنا بنتكلم على hypertension in general.
احنا بنقول على
in general
لو عنده هايبرتنشن هياخده قبل السيشن، انما لو ما عندوش طبعا انترا دايركت هايبرتنشن يستحسن ياخده بعد السيشن.
تمام.
طب عندي سؤال للدكتوره منى بعد اذنكم.
طيب دكتوره منال لحظه واحده بس، هقرا سؤال الدكتور نواف النعيمي. ان CKD plus or minus diabetes regardless to blood pressure control for starting RAS and SGLT2 inhibitors يا دكتورة منى. Which is better to start with? Is it ACE or SGLT2? yes.
تمام. لو عيان diabetic يبقى برضه الصوديوم جلوكوز ترانسبورتر will be first choice in the diabetes treatment. يعني in his diabetes treatment sodium glucose transporter will be the choice. تمام. Then the ACE inhibitor for the kidney.
And for the proteinuria.
And for the proteinuria.
For the proteinuria. ما هو SGLT inhibitors are the miracle drugs. They are used everywhere. To an extent يعني إن الواحد بيشك في قدرتهم. If you use a drug in every about 5 or 6 major indications or major diseases, it's not very convincing يعني. If I'm heading to treat proteinuria of diabetic nephropathy, will I go for an SGL2 inhibitor ولا ACE or ARBs? Which is more efficient? Or combine? انت في الاخر قلتي option of combination مش كده؟
combination بس حضرتك
اتفضل. I think it is يعني الاثنين are recommended. فكرة الانيشيشن which of which يعني according to guidelines الاثنين recommended for a patient with proteinuria. which of which
بس لو دايبيتك يا دكتور ياسر يبتدي SGL2 انهبيتور اوريدي، لو هي ماشي هيبتدي عليه من الاول او كان ماشي عليه، ولو هناد اون الاس انهبيتور اور اربس يبقى بعدها بس سيكونشال، يعني بعدها ب 15 يوم تقريبا، يعني مش يبتدوا مع بعض الاثنين يعني.
او
هي منى اتكلمت على كومبينيشن في الاخر.
ايوه بس هي الدكتوره منال عندها بوينت ان احنا هنبداهم الاثنين. الصوديوم جلوكوز ترانسبورتر هيكنترول الجلوكوز، فاحنا هنبدا بيه وبعدين if we start both simultaneously we can risk a dip in GFR. يعني maybe the GFR is reduced because we started both of them. فعشان كده it is preferable to not to start them at the same point.
This is the point ان احنا not to start both at the same point. هنبدا which is يعني which is urgent يعني
الانتي دايابيتك طبعا.
yes anti diabetic or anti hypertensive. لو البيشنت needs anti hypertensive يبقى هبدا بالانتي hypertensive more than anti diabetics، وبعدين initiate the second at the later step. بروفيسور منال بليز.
هو دايما يا دكتور ياسر هي تيلورد، يعني هي حسب البيشنت نفسه. يعني البيشنت اللي بسيفير هايبرتنشن، عنده هارت فيلير، عنده، يعني هي بتعتمد على البيشنت نفسه. يعني هو هل جاي بسي كي دي بروتونوريا بس، يعني البروتونوريا ممكن يستخدم الايس بس، يعني دايابيتك وبروتونوريا ممكن يستخدم الاثنين. حتى موصوف ان هو يستخدم الاس جي ال 2 انهبيتورز او الايس انهبيتور او الام ار اي، ممكن يستخدموا بس سيكونشال، كل واحده فرق بينهم من كل واحد والتاني اسبوعين على الاقل عشان ما يحصلش جي اف ار دروب.
تو دراجز.
هو كان السؤال بتاعي للدكتوره منى، بس هقول السؤال بتاعي. هو لو العيان جاله هايبركاليميا يا دكتوره منى، يعني خلاص، يعني اوريدي في السايد افكت بتاعت الايس انهبيتورز او الادويه دي، انت احسن حاجه نستخدمها في الهايبركاليميا ايه؟ هل نستخدم الصوديوم زيركونيوم، يعني ده مكتوب في الجايد لاينز، ولا في حاجه ثانيه نستخدمها؟ وطبعا لو في هايبركاليميا واحنا محتاجين الدراج هارت فيلير هنكمل عليه.
we have to attack hyperkalemia and at all levels starting from the dietary intake. And then we start, if the patient is for example slightly hypertensive, we have to give him a small amount of diuretic in order to make him lose a little bit of potassium. وبعدين we can give him then the new potassium. Yes.
When do you stop the ACE في حالة resistant hyperkalemia? You have to go for the very expensive drugs, ولا I can replace the ACE with the ARBs?
If I cannot afford the drugs, sometimes these new drugs are very expensive.
Yes, that's true.
But I will deprive the patient from the benefit of ACE and ARBs.
Yes, this is the important point. If you allow me, the benefit of ACE and ARBs outweighs the financial issues. يعني لو عيان هارت فيلير، لو عيان بروتينوريك، we should not stop ACE and ARBs except if severe hyperkalemia resisting even للنيو دراجز اللي هو الدراجز الادويه الغاليه يعني.
ايوه
في هذه الحاله
هي مكتوبه في الجايد لاينز يا دكتور ياسر، اخر جايد لاينز بتدي له كاتبه ان هو لازم هنستمر على الايس او الاربس، وبعدين لو احنا في هايبركاليميا هنعالجها. انما يعني وعين
سيرش فور اذر كوز، وبعدين هندي مانج الهايبركاليميا كرونيك هايبركاليميا سواء اذا كان بالصوديوم زيركونيوم بالذات اللي هو النيو. وبعدين في الاخر خالص should think ان احنا decrease الدوز، وبعدين اذا كان بقى ما فيش اي ريزيست نفكر ان احنا ستوب لاست بوينت في اللاست اوبشن.
هو برضه عشان ما نجلدش ذاتنا يا دكتور ياسر، مع احترامي للوكيلما او تيفر، يعني مش عاوز اسمي اسامي تجاريه، او صوديوم زيركونيوم او غيره، في دراسات كتيره معموله وحديثه مش مبينه فرق شاسع بين اللوكيلما والكيكزاليت او في الافكت، عشان نكون صريحين بعيدا عن الكونفليكت والتريست. ممكن يكون السايد افكت بتاع الكيكزاليت اعلى سنه في الموضوع الكورونيك برفوريشن او كده، لكن اوفر اول الاوت كام بتاعهم الاثنين اولموست ذا سيم. فممكن نشتري برضو، هو نسبيا طبعا الكيكزاليت ارخص كتير من اللوكيلما،
بس لازال غالي برضه يا دكتور
نسبيا
سعيد.
على عيانينا ممكن يبقى سنه غالي، لكن الثاني غالي جدا. الثاني يعني الثاني طبعا بيخش في الافات، يعني 5000 6000. فطبعا
لو محتاجينه اسرع يا دكتور،
لو محتاجينه اسرع يا دكتور احمد.
لا والله بصي هقول لحضرتك على حاجه يا دكتوره منال، مش عاوز ادخل في المنطقه دي، بس تعتمد على قوه الشركات والضغط بتاعها. معظم الابحاث قايله ان مفيش فرق شاسع قوي. احنا طبعا بنجري ورا الجديد والكلام من
انا
ده،
بدي
ماشي
الارخص والله ماليش دعوه
لا ما اقصدش حضرتك يا فندم، ما اقصدش، لا يا
بس
دكتوره منال والله ما اقصد حضرتك،
بس قصدي في واحد اسرع من التاني شويه برضو، يعني مثلا لو احنا في ايمرجنسي او كده ممكن نستخدم الاسرع.
والله
يعني
افلحوا ان صدقوا.
لا إذا كان على أسرع بقى هتدي بايكربونات
نغسل
هديها سكة
العيان
تانية
بقى.
ودياليسيس وكده.
دكتور احمد بيقول according to guidelines الاي دي اي، هو نفس الكلام اللي احنا قلناه، ان احنا لو هنبدا بواحد منهم، ان ماكسيمال توليريتد دوز اوف اس انهبيتورز الاول وبعدين الاس ال جي تي 2. لكن طب ما هو لو العيان على اس ال جي تي 2 هبدا الاس انهبيتور، ما هي بس هو العيان الاول نوصل للماكسيمال توليريتد دوز وبعدين نبدا الاس ال جي تي 2. اعتقد الاس ال جي 2 يس الاس، ما كلنا اعتقد الاس ال جي تي 2 حتى في الكي دي دلوقتي بقت هي اوف برايمري بنفيت، يعني او ليها بنفيت ايكوال. الماي براكتس انا شخصيا بدي الاس الاول.
لها مايلد، مش هقول ان هي انت هايبر كاليميك، لها مايلد انت هايبر كاليميك افكت.
انا الماي براكتس
طبعا ما نعتمدش على القصه دي قوي،
ببدا الاول الاس انهبيتورز قبل الاس ال جي 2. لكن طبعا اي حد يعني كل كلام البراكتس تحترم، يعني
اتفق مع الدكتوره منال والدكتور دولت
كلها جايد لاين
دكتور احمد،
كلها جايد لاين بيست. اوكي ايه تاني؟ طيب I have a question دكتور، I have a question about البريتونيال dialysis دكتوره منى. حضرتك اتكلمت عن الهيمو داياليسيس، ولكن البريتونيال داياليسيس هل the same or preservation of residual renal function of peritoneal dialysis with ACE inhibitor? Do you have any some information about this?
لا unfortunately not.
انا قريت الحته دي كتير يا دكتور ياسر، بعد الدكتوره منى وحضرتك ما فيش ريزلت قوي مبشره في هذه القصه. يعني استخدم ايس او اربز لمجرد ان انا عاوز احافظ على الريزيدوال كيدني فانكشن. معظم الريزلت ميكسد ريزلت او مايله ان ما فيش بنفيت للدرجه اللي هي
ده سيم تقريبا از كل الستادز الموجوده في
سواء في الهيمو او في البروتونيه. حكايه يعني البريزرفيشن وان كانت في كلام كتير يقول لك خليك على الايس ممكن يحافظ على الريزيدوال كده. معظم الدراسات ما اثبتتش هذا قوي يعني.
هو ايفن البروجريشن وذاوت بروتونوريا حتى دي فيها قولان يا دكتور سعيد، حتى كنا اتكلمنا فيها من زمان قوي.
دي حقيقه يا فندم، دي حقيقه.
دي بروجريشن سيروجيت اند ماركرز اند بوينتس، يعني البروجريشن يعني في النهايه without بروتونوريا الافكت بيبقى الايس ساعتها هنا mainly for control of hypertension. without بروتونوريا هو mainly هو دراجز كنترولينج فعلا البروتونوريا بشكل كويس، وبالتالي بينا على البروجريشن. without بروتونوريا كافكت على الريدكشن اوف جي اف ار questionable برضه، مش ذات marvelous effect. طيب اوكي دكتوره دولت we have no more comments and I
لا الحقيقة يعني
discussion
very rich evening يعني، استفدنا جدا يعني.
جدا الحقيقة. اوكي طيب no more questions. اوكي شكرا جزيلا لحضراتكم. شكرا. thank you دكتور منى for this very interesting.
شكرا يا فندم. شكرا
بروفيسور دولت for this very interesting session and for all professors who shared us, Professor سعيد خميس, Professor أحمد سعيد, Professor منال الديب, and for sharing us, and thank you for everyone. Thank you, Dr. Abdurrahman Al-Maghrabi, lecturer of medicine and nephrology in Cairo University, and he is the now the vice head of internal medicine hospital in Cairo University, and hope to be in the coming years the head of the internal medicine hospital. Thank you, Abdurrahman, for being the coordinator of this session. Thank you.
Congratulations, Dr. Abdurrahman.
تقريبا حوالي
مبروك يا
شهر
دكتور عبد الرحمن.
متشكرين قوي.
نائب مدير مستشفى الباطنة عندنا. نشكر حضراتكم، شكرا جزيلا. ثانك يو فور ذس.
احنا متشكرين قوي.
شكرا جزيلا.
احنا اللي شاكرين لحضرتك ودكتوره منى ودكتوره منال.
احنا ميعادنا اتغير بقى 8:30 مش 9 في الشتاء، 8:30 علشان الوقت بقى بدري شويه، فيعني بننبه ان شاء الله كل مره. هي كانت مكتوبه بس يمكن الناس ما خدتش بالها قوي.
معلش انا بعتذر عشان متعوده على 9.
لا الكل دخل الحقيقه النهارده 9. احنا خدنا بالنا من كده، الناس كلها لسه ما اتعودتش على الميعاد الجديد. 8:30 في الشتاء اعتقد.
التوقيت الشتوي ده التوقيت الشتوي.
ايوه.
شكرا جزيلا.
شكرا.
تصبحوا على خير.
مع السلامه.
مع السلامة.
سلام.